The topic is a worldwide topic, we know, and therefore I have some charts. And I mean, the first chart here is a chart, the facts and figures of Tunesia. And as we have already a lady here on the stage, which is from Tunisia and knows the country very well, I want to pass the first question related to this chart already to Dr. Donia Koubaa. Tunisia is an emerging nation and faces serious challenges, right? So what is the answer to fight against a non-communicable disease? And can you tell a bit more about your specific challenges you have in Tunisia today? I think we also need some micros. Okay, it's working.
Okay. Hello. Thanks first for invitation in the panel discussion.
So there are
the first question.
So the first question is, Tunisia has a special challenge regarding the population. So especially regarding non-communicable disease.
Yes.
So how do you? Where's an answer? How do you fight against this challenge?
Yes. Tunisia has developed this during these many years. Has developed the device and system of health, especially in the general population, and has made regulations and many preventive programs, which improve health indicators for communicable disease. But for non-communicable diseases, the statistics are alarmant. The numbers of diseases, cancer, cardiovascular diseases, diabetes increases. And there is a reform of strategy of health with also with the World Health Organizations, and to make programs, preventive programs, more efficient, especially for non-communicable diseases, and to make much better cooperation and collaboration between health and sports, because we are two ministries. Ministry of Health and Ministry of Sports. And I work in the Sports Medicine Department, National Center Sports Medicine, which is under the Ministry of Sports.
I have a special question. I mean, if I look here at the 30%, especially of women, have the problem with the weight, and 62% are overweight. So, I mean, is this a common problem in, let's say, states like Tunisia, like Morocco? So, is there the female population not active enough? And how do you have programs to teach those women to be more active?
Yeah, the causes are the best causes. The main causes of obesity and overweight in Tunisia are the low inactivity, because it depends, I think, in the main lack of means. I think everybody is aware now that physical activity is the best mean to prevent obesity. The state made many programs to awareness, to aware people to do physical activities, but there are many constraints which depends on the main in order to make the preventive program more efficient.
Okay, so perhaps about the efficiency of those programs we can discuss a bit more further if we go further with our charts, because the next chart is now Germany. Here we have Germany. How is there the situation? you see that in Germany, the men are the problem. Yeah, so we have 67% of the men are overweighted and 53 of the women.
Yeah.
Obesity is not as much, but this is directly a question to Professor Steinacker. What are the action points, and what do you want to tell us about these figures?
Yeah. So Germany is coping up and is leading. If we look in this room, we feel that there is not a problem with obesity, but there is a real obesity in society. So we have a two-split society, which is now not only in Germany. We have people who are fit, who are slim, who do exercise and have a healthy lifestyle, and we have one half of the population has a problem. And we, as with our common system, we don't approach them. We teach them that they are unhealthy, but that is the situation in school. They are not successful, and they feel not successful, and so they don't respond to traditional approaches. Mm-hmm. And this is a challenge which we are facing. The traditional medical system sends the patient home, you failed. You are obese, you have diabetes, hypertension, you are the problem.
But Professor Steinacker, since 2016 we have the law which was coming into effect in Germany about prevention. And do we have now more doctors which are prescribing exercise? And where we are at this implementation of that law?
We wrote an application, and I asked my regional chamber of physicians how many prescriptions in Baden-Württemberg have been done. And it's less than fingers in one hand.
Okay.
In Hamburg, it should be much more, but the problem is it's only, this is a first step and it's very important, but the doctors are left out of this prescription. They only have to prescribe, but they are left out in the law. And therefore, the law is good. To have a law is always good in Germany, but the problem is it's not only a law, it's a societal effort. And we have to organize it. Politicians don't organize it, we have to organize. And that's about we need exercise medicine.
And this is a topic where you initiated already an own network, right? AxisMed, to drive that a bit further. Could you tell us a bit more about this AxisMed approach and what the status of this project is at the moment?
We as Exercise Medicine Germany said we have to create a societal movement, and we called it AxisMed because to make it more easy to pronounce, and this means German doctors should be involved in this movement, and we get now about 20 institutions who signed it ahead the German Chamber of Physicians. Several state chambers, Hamburg, Berlin, Baden-Württemberg signed it, and several others. That means we have now a lot of other universities, and this is the first step now to create it. And our idea is we want to have introduced this in model practices, private practices. And this is model private practices. We also have a health educator or a movement educator. That means the doctor needs not so much time. He has an technician assistant who is educated and then is a partner of the patient. The doctor is initiator, facilitator, and the technician or the assistant is supporter. And then we want to create local networks which work together.
I think the networking is a very important topic because here is mentioned insurance, and I think how is the relation to insurance industries? And I mean, we saw an approach, especially coming from my industry, from the wearable industry 3 years ago or 2 years ago, with a Generali, and they had a big problem afterwards, press-wise, because it was they wanted to give out cheaper insurance policies to people who are more active. I think that was a wrong approach because it's against the whole insurance philosophy, but to give points plus points. I mean, even to be active and to get some miles for flying cheaper or whatever. I think these models should be enlarged a bit bigger or wider and combined perhaps with your activities, or is this not possible?
Incentives, there's a lot of studies on incentives, and incentives work at the beginning, but they don't, the behavior is not persistent when you give incentives. You have to increase incentives, and that is not possible. In an optimal world, you cannot increase incentives all the time. So the real incentive is that you get the mind of people. And often insurance companies are not interested in the mind of people, they are interested in cheap insurance people. So if you are perfect for insurance company, you pay a lot, and you are not ill because you exercise. They are not interested in this other 50%. This 50% who have a problem are not in the main focus of insurance industry. And that is a problem of legacy. We need other people to drive it. Maybe they have to pay a little bit, but they often don't want to pay for common interests. They only want to pay for themselves.
Mats, what do you think about that? So what is your, I mean, you are representing the role model a bit, but just regarding the prescription topic, you have, the rollout is done prescription-wise in Sweden, so doctors and physicians, or just doctors are able, or physiotherapists also, or who is the,
also physiotherapists and nurses.
Prescribe?
So healthcare personnel with who has the sufficient knowledge could do that, and it should be in a team. So even if it's the difficulty for the doctor is always the time. So this could be best to do in a team. But it has to start from somebody who has the patient, the responsibility of the patient, and to identify the problem. And then somebody else can help and do the practical work, and they can together form a good prescription. And also the follow-up, but I think the key is then the connection to the network outside the hospital, because you're not supposed to train in the cellar of the hospital, so to speak, with a physiotherapist. You're supposed to go out in the real world with your prescription and get help in a network of regular gym chains or people are associated to this, because they are not taking any responsibility for the patient. They are taking responsibility for providing the kind of activity that you have prescribed. So this is a difference, and I think in our country we got a big network of people who are interested to provide this, and training facilities and centers and so on. So the problem is not them. The problem is us, who should prescribe more prescriptions.
But upfront to the prescription, you're doing a health check based on it's a real physician who's doing that.
Yeah.
So it's not,
I mean,
it's not a physiotherapeutical.
No, it could. I mean, in a way, it could come because you have all these diabetes. What you call them? The diabetes nurses and they have connection also a doctor behind them, right? And the responsibility ultimately is the doctors in a way. But there is this initiative could come from the nurse or the PT, yes. But they will also always discuss with the doctor, because there might be other contraindications and medications that can influence and so on.
Okay. So we are coming to our next chart, and the next chart is the small country, US. So, I mean, we discussed that yesterday already at your speech, Larry. But I think we should also take a look, and I think especially if we took a look here on diabetes too, suddenly it's not good. But you are perhaps a world leader.
Perhaps.
So, what could you tell us a bit more about your status there regarding the prescription topic, and you also made some comments regarding the insurance. So perhaps you could combine that a bit.
Okay, there's a number of things there. Let me just start first. Yesterday, I showed that the projections, not only for the United States, Brazil, China, and Germany, it's only going to get worse. And in terms of if we don't make changes now. And if we go back historically and look at from the turn of the 1800s into the 1900s, we're trying to remember what happened then. And that was the Industrial Revolution took place around the world, especially in the industrialized nations of the at that point. And the United States was one of those who was one of the leaders in industrialization. Not the leader, but one of the leaders. And what did we promote in the 1800s into the 1900s? Work-saving devices, all the way up through the 70s and the 80s. And then all of a sudden we realized that, hey, the incidence of cardiovascular disease is really getting great. It's huge. And the projections show that to get worse. And so my point is that it took 80 to 90 years for us to realize that we need to be more recreational. And I use recreational here in terms of include physical activity. I do like, you had a great presentation a few moments ago. And I do believe in physical activity around the work. I park my car in a parking lot when I don't go to work anymore. I just go to the office. I'm retired, but I go to the office. I don't go to work anymore. But I park my car, and I've done it for 35 years in a parking lot, and I walk everywhere on campus. I have some friends who park beside me and then get in their car to drive 200 yards to have a hard time finding a parking spot. And that bothers me a little bit. So my point is, we have set a culture, as you spoke about, a culture in the United States for not being physically active. Just recently in Lancet came out some information, and in there it indicated that people who are physically inactive in the United States is only about 28%. I don't believe that. That means then that 72% of the people meet the recommendations and are physically active. And that's not true. There's a lot of problems with some of those kinds of data. I'm not knocking the paper, but it is confusing to me. It's confusing. My point is that diabetes is getting worse, obesity is getting worse, and it's not just in our adults, it's in our children. Okay, so we've established that disease, not just in the United States, is going to be worse. The projections are to be worse around the world. And what I said yesterday is, let's focus on our kids. If we get our kids to be physically active, then we can be physically active with them, or we should be physically active with them. So I think that takes care of part of your question. The other is, health-wise, or health insurance-wise, what's going on in the United States? I wish I knew. I'm very pleased to say that I worked for the state of South Carolina for 36 years. And so when I retired 10 months ago, December of last year, I went on to Medicare, but I still could carry over as a secondary insurance my South Carolina state insurance plan. So I'm pretty well covered. But I worked for 37 years, 36 years to have that. Not all the people in the United States are that fortunate, especially the people who are the entrepreneurs. And the entrepreneurs of the world are probably the most important, who don't necessarily have those opportunities of large personnel, as we have in the state of South Carolina, to be involved in insurance plans. So are the health plans made for the assured people or the wealthy people? Well, no, not necessarily, but it's taking advantage of those kinds of things. So it's an individual. Where am I going with this? In those individual plans, I have, this is anecdotal data, I have a very good friend that I've known for 35 years since I moved to South Carolina, 36 years since I moved to South Carolina. And in those 36 years, I watched him get heavier, heavier, and heavier. About 8 years ago, he took on a new insurance program with his company, and there were incentives. And his name is Brell. I won't give you his last name, keep it a little anonymous. But Brell, we travel with him on holidays, and at 7 o'clock every morning, he was going out to start his 10,000 steps a day. Because if he got 10,000 steps a day every day, and at least 3,000 of those were at a higher intensity, and they gave him a special watch to wear that reported directly in, every month he got X dollars off. Or every week, like it was like $10 off of his insurance, and that he was paying annually. And that to him was about $500 a year. He loved that, and that was his incentive to keep on going to keep on being physically active. He retired 8 months ago, and we traveled with him this summer, and he and his wife. And I said, come on, bro, let's go get our activity. He says, oh, I don't have the incentive anymore. He didn't say the incentive. He said, I don't make money anymore, and I'm not going to be physically active with you this morning.
He directly stopped.
No, he stopped.
He directly stopped. It's amazing. It's amazing.
I want to reinforce what Jürgen had to say is that incentives are important.
Yeah.
And now, the last point, and then I'll stop, is that there are new programs like that opening up in the United States, but they're not the majority, they're the minority. And I do think they're important, and for some people, such as Brel, it's monetary incentive. They reduce his insurance premium with that.
I think starting with perhaps the ill people, starting with the people who have the problem of being overweighted. I mean, then it makes totally sense. It's right what Professor Steinhager meant. For me, it's a wrong model for the rest of the insurance people, but for the people who are overweighted, it makes totally sense, I believe, and it showcased your friend directly. But did you also try to get him on another route? I mean, he was a friend, or he's a friend of you, and you were drinking together beer and wine and whatever, and are you then so open to him and tell him, hey, that's the wrong road. You have now 140, 50 kilos.
I wouldn't be a clinical exercise biochemist behavioralist if I didn't say, come on, bro, let's go have a Coca-Cola together. Of course, I have soda water. He has a Coca-Cola. But he has Diet Coca-Cola. And talk about that to encourage him. I will say this morning, 8 o'clock South Carolina time, he is undergoing a pacemaker procedure. So my point is, there now is his first wake-up call, and he's, I think, 64 years old. So there is follow-up with him. There is follow-up.
Here, we have here the picture, cardiovascular disease. United States is not as high as Brazil, but you see that's really a hot topic, and diabetes too we have here, and obesity is directly related here to diabetes too. Yeah, but thank you so much for your insights, Larry. It's amazing insights. So the next company I have to show you, it's I need the next picture here of the next the next country, Italy, because we have Padova here close to me, and now we need the country Italy, please. The magic guy behind the laptop has to show us now Italy. But we don't need, here we have the figures of Italy. In my opinion, so if I go to Italy, I always see a lot of people on the bicycle. They all try to be the star of the Italian bicycle tours, and so, but this is perhaps not the real picture, right?
Not really, and actually, Italy is not everywhere the same, and probably if we talk about the level of physical activity is different between North and South Italy, for example. We are really higher level of sedentary lifestyle in the south, while in north part of Italy, for example, in Veneto region where I live, and also in Trentino, that is really close to Austria and Germany, they're really quite active, but also even though they are active, there are still a lot of sedentary people. And we can see the data, and they show that not only sedentary lifestyle, but also obesity and type 2 diabetes is increased in the last few years. So it's a quite large problem, similarly to the other European and US country.
So, and you have also installed already the system that the doctor could prescribe exercise, right? What is the outcome? So what is the result? So is it really running in the right way? So
the main problem, I mean, there are a lot of problems about exercise prescription. What I think is the main problem is the medical culture. So we need a better medical education, because most part of our physicians never heard during their medical studies about exercise, physical activity, the importance of exercise in chronic diseases, the effect of exercise in chronic diseases. We started just a few years ago, at least in Padova and also in our university, to teach them during the medical classes, because even though it's not just a problem about medical, as a physician, it's a general problem, but the awareness of physicians is very important, because they are the first step to they need to prescribe and convince them their patient to exercise.
But how could you teach better to the doctors and physicians that there is a model out there which is meant to be exercise as medicine? So how?
How?
At the university, do we have to start at the university
I
directly?
I can talk about the Veneto region, my region, where what we can do, we are doing actually. At the university, I'm teaching in the internal medicine course, and I teach to students the exercises medicine idea. But we are also trying to train physicians, all the specialists, and also the general practitioner to learn the importance of exercise, the effect, and how to prescribe exercise. Because it's really rare and depends also from the personal culture of physicians. Maybe there are some physicians that is very active, very interested about physical activity, so he's also interested that his own patient do physical activity, but other physicians are really far from the idea of physical activity as an important part of therapy.
Do you check that if your students are really adapting what they learn in the real life? So you have an alumni for sure,
we don't have so far any follow-up because we are starting right now. It's really quite hard because it's really to create a network, a system where you need to create physician. We are creating also something we call health gym, that are where we have the exercise specialists, and this is for chronic diseases, for people more with the bigger health problem, and they should receive the exercise prescription from physicians. But even the problem is not completely resolved, because we know that we cannot think about that all patients should go to the gym, because many people prefer to go outside. So it's a problem it's a cultural problem. It's a problem to involve different professional figures, not just physicians, not just exercise specialists, physiotherapists, nurses, but all the world, probably also the architecture, people that think about how organize the city is important to improve. We know very well it, but I think that we need to start, and each one should try to do his best to improve, to give his help to the general system.
So then in 5 years we have the first doctors from Padova, which studied in Padova, and I could recommend my friends in Italy, they should only go to doctors from Padova. Okay, so the next country is Portugal, and I was just recently in Portugal, and the meat is quite good, but also quite heavy, right? So that perhaps should be also reflected here in the figures. Yes, we have obesity in women and men, but it's not as high, I have to say, as in the rest of Europe. So are they already active, or how is the situation in Portugal?
Yeah, I would say that during the last years we were able to change what I call the social norm regarding physical activity in the adults. So we are becoming more and more active, and that's curious because the data that is there, so that 62% of the adults in Portugal that comply with the physical activity recommendations, that's true because they are based on the criteria that we do not need to comply anymore with more than 10-minute bouts. That's a very important issue that I want to raise in this debate here. Because for several years, the WHO had this kind of criteria. And for the same data that we have in Portugal, that is based on objective data. And if you consider also the Swedish data, the English data, and the Norwegian data, so if you use the former criteria, only half of this figure, of this number, really meet the physical activity guidelines. So that's something that we need in Europe. That's something that you need all over the world. It's really, first, do not anymore to rely upon questionnaires, because if you look at the Eurobarometer, Portugal is really different from the northern countries in Europe. But when you compare with objective data, we are similar to what happens in Sweden and in Norway and in England. So we need, first, to have objective data. Second, we have to have harmonized data. And I can foresee that in the next 5 or 10 years, we will have all over the world harmonized data that we can look what are the determinants, what are the mediators that really influence these kinds of physical activity. In Portugal, we have a physical activity national program that is ruled by the Ministry of Health. There is a body in which there are representatives from the health sector, from the sports sector, from the education sector, and also from the department that is in charge of all the territory organizations. So that means, based on that program, since 6 months ago, it is mandatory that at least 25% in the health centers, primary care physicians must to have a very brief assessment of the vital sign, physical activity. And those that do not comply with the recommendations, there are what we call brief advice. That's something that I want also to bring to this discussion, because from my understanding, exercise prescription is really something different and needs a very clear diagnostic assessment in order to have prescription. Our model in Portugal is something like this. In the primary care system, there are what we call brief advice. Basically, that's curious because the new document that was published by WHO, in the old document, that's the first document that deals with just with physical activity, because the former documents, physical activity was always together with nutrition. That's the first one. All over the position, they talk about brief advice. And brief advice needs something that we need, and we have a program in order to develop skills for this very brief counseling, 1 minute, at the most 2 minutes, to be really influent. And that's something that on the top of that, we are doing some kind of education. And then the model includes also some referral to the community resources. And based on the community resources, the system, the ecosystem, recognize places where there are recognized exercise physiologists for more detailed exercise prescription and follow-up, and then back to the health system. And overall, this is basically our system is built. And on the top of that, we have a surveillance system. The data that is in here, that I've shown here, that was data collected 10 years ago. We are finishing a new surveillance system, and let's see what's going on. But I'd like to make this point that you really need to have a good tool in order to assess the effectiveness of our interventions. And it seems that we do not have that tool because we are measuring this complex behavior in a very different way. And so we need to have some kind of consensus in order to have some kind of also standardization in order to assess how effective are our intervention at the national level and also at the international level.
Mm-hmm. We have now the charts here behind, and they are explaining a bit also what you mentioned. So 38% did not meet the physical activity recommendation defined to 30 minutes, but 79% of the participants did not meet the physical activity recommendation when it calculates the percentages based on the 10 times.
Yeah,
so 10 minutes.
Yeah, that was data that we pulled together from these 4 countries, and we assessed the data with the different criteria. And interesting enough, the new guidelines from the US, they just removed these criteria. And so what does that means? From now on, I can expect that WHO will also follow this suggestion. And that's a very important step in order to have a good criteria, and then to get more data all over the world. So, and then again, to look at what are the most efficient models, and also to change the models if they really are not effective.
But it's a bit different to your approach, right? A bit, and for that I will showcase also the Swedish figures because we don't have them here, and now we have also Sweden here.
Yeah, I think you're telling us a little different model, and I think that's welcome to have different models. I would also like to emphasize and stress what you said, that what we have done in our country, because this model was introduced 15 years ago, and what we've done now is have the first systematic review now. So it takes time to do research on this method. And now we can see it works. So hopefully you will have the research done in Portugal to see if it works, because that's the key. And I think many models can be tried, but it's very important to evaluate them, because we think a lot, and but we have to know.
But it's a bit, okay.
Actually, we are running right now a pilot study, just looking how effective is this kind of model, in which the primary care health physicians, they do the brief advice, and then those that really need some kind of referral to exercise physiologists, recognized exercise physiologists in the community, what is the effectiveness of this kind of intervention as compared with the standard care model. So that means that we need interventions, we need to assess, we need to have to look how really these models, we believe on the model, but then we need to have outcomes that really help us in order to follow the same track or change the track of our approach.
As we have the former president of the Exercise Medicine organization here on the stage also, I mean, Larry, we are talking about individual approaches for the patients or for the people who have obesity. We are talking about individual models for the countries at least. I think a common model for the countries or for the nations would be for sure a good approach, and I think this is also something what the American College of Sports Medicine was trying to roll out globally, right? But it's not adapted in that way till yet.
So first of all, the concept of global standardization is a huge idea.
Yeah.
And I've had the opportunity to travel around the world the last 10 or 15 years, and one of the things that I have learned from exercise medicine especially is that every country has their differences, and if you almost every country, not quite, but almost every country has recommendations for physical activity. They're not exactly the same but they're generally the same. They have very close similarities. And the whole idea is to get people physically active. What I've learned from what is exercise is medicine, where I unfortunately was so very wrong, is we have the right way. We don't necessarily have the right way in the United States, because the right way in the United States may not be the right way for Italy. It may not be the right way for your country and across here. But so global standardization, as your question was pointed to, I think is not there. But maybe it's coming, because as Matt said, you've made some changes after you've implemented the kinds of things you're doing in your homeland, and as you just indicated, we've made some changes in what we're doing, and part of those changes was the prerequisites to get into an exercise program. I think is what you're referring to in terms of having testing or not testing. And what we've said is, if you're disease-free, perhaps you don't need to go through the testing, the complete testing, because that is a barrier. That is a barrier for some people to say, I want to start an exercise program. Okay, you have to do all of these tests before you do that. And we have removed that barrier. Now, on the other hand, if a person has some kind of chronic health condition, then we need to know more about that health condition, the medications that go along with it, and how all of that would impact an exercise prescription. So we are evolving. But going back originally, globally, we have a lot of talking to do. I think there is some movement out there to work globally, and I encourage everybody to be part of that global movement to better understand the overall needs, because what is needed in your country is not necessarily what's needed in the United States. And one last comment, and we may get to this, and I may preempt you. We haven't gotten to the grassroots. Down where in the trenches, I live in the trenches. I don't mean a ghetto, I don't mean anything, but I work down there. I have a family that's rural farmers from Ohio, and the reason my brother exercises is because I told him to. I told him.
Very good.
And he's been exercising. Now he's a pretty big fella, but he's been exercising. He's been driving too many of those big tractors, 200 horsepower tractors. But we haven't gotten down to the grassroots, and we need to really continue our efforts there.
So Professor Steinegger has a comment on that.
We need some standardization when we report to activity. We know now that talking with a patient about activity is important, but what he tells you is his perception. His perception is important, but it's not the reality. So we need, and this is the industry providing us more possibilities to measure really activity, cheap activity measurements. 10 years ago, we introduced in cardiac patients, we had an activity monitor costs about 1,000 to 2,000 euro per monitor. That's not a mass product. That's an advantage. The second, which we also should measure, is body composition. And we have a misconcept of overweight. The farmer, normally the typical farmer has a body mass index of 28 to 30 because he has muscles. This is not overweight. This is a muscular man. And so we need also to measure simple waist circumference. We don't need, not every time we need a body composition measurement, but we need also to tell patients the right concept. Not every BMI of 28 is really overweight. It could be positive to have muscles and have a BMI of 28. So we need also talk the right things and measure the right things.
But I think it's not only measurement, because I mean, I'm representing the wearable technologies organizations, but at least I think it's more a behavior change, and the behavior change is not only coming from the technology, because you could measure everything in real time and get the feedback directly.
It's not about, but we need also, when we talk about obesity rates, when we talk about compare countries, we need also to have the same data.
Right.
The data, as a scientist, enable us, but we need to change society. That's quite clear. And even in the second world, Tunesia is a well-educated country, high education standards, but low means. And that in this country, you see really infectious diseases are under control, but the social dimension of inactivity is not under control. Even if the government knows it. Yeah.
Yeah. I want to open it a bit for some questions from the audience. He's really getting a gold medal, I think, after the sports medicine conference. So please, our first one.
Does it? Oh, yeah. If doctors already are learning for about 7 years to be a doctor, why not add like a few months of a personal trainer diploma into the course of medicine? And then in that course, teach them whatever.
Very good question. Who want to answer that question?
I think definitely it should be much more on lifestyle, behavior techniques and exercise prescription and so on in our educations. But I do think we should have it all through the medical system. You hear about diabetes in all courses from you start med school until you finish, and then you know about diabetes when you finish. We should have physical activity in the course of internal medicine, but also in surgery, because we know it works. And we should have it when we talk about cancer and orthopedics and mental health. So I think we should have physical activity coming in every course as a stream during the education to help us know the importance of this and as a perfect treatment tool.
I'd have to add something. I think Lewis has something. In the United States, medical school curriculums are really jammed. Your point is a question that has asked many times. You know, how can we get lifestyle management, more of that information, which not only includes physical activity and exercise, but nutrition, stress management. There's a number of things that ought to be covered in. Smoking, thank you very much. The problem is the curriculum is already jammed, trying to make room for that. So one of the things that we thought about in South Carolina is, how can we get that into the undergraduate curriculum so that when, for example, 40 years ago, when before I went to South Carolina, I was working in a clinical exercise program in Ohio and with students, and I said, when my day comes and I go to a cardiologist and I really need a cardiologist, I want a cardiologist who understands lifestyle management. And I think that really starts, I think it's, Matt, what you're talking about is we need to start it at the college level. And if you're going to be a pre-professional kind of person, you need to already have that information.
I mean, the question was good that we have even some comments.
In Portugal, at the University of Lisbon, medical doctors, we did the scope of the preventive medicine course. There are some information, not really regarding the physiology of exercise, because they know that, most of that, they know. So the issue is really to develop some counseling skills, because we have learned in our interventions that's much different if you deal with the patients with, let's say, for instance, with a model like the self-determination theory. That's the intervention is much more skilled. It's much better as compared when you just are counseling without any kind of theory behind. So that's why we need to improve not the biological grounds about exercise, but how really to be influential in the counseling. And that is probably the major roadblocks for medical doctors to be effective with the good influence in the patients. Not really biological information, I would say, because they have most, I would say almost, of the information that's important for exercise.
Professor Steinhager.
We have a huge load on our medical students, and the study load, it's really a problem. To be a medical student is really tough work. And the problem is, and then the students focus, let's say, when a patient lies here dead on the floor, he wants to be emergency helper. He wants not to have dead patients. You want to resuscitation. So the resuscitation course is the most important course for a medical student, but he feels helpless for a lifestyle. So he omits lifestyle because he feels helpless. He tries to focus on practical things, resuscitation, emergency, infusion, practical things, and that is a problem. We need really to give him practical advice to solve this very complicated problem, to convince patients to change. And this is a high level. Even most students think they are helpless. They can do it, and we can provide solutions.
So we have a next question here in the audience.
Stealing a point from Dr. Holdhouse this morning, correct me if I'm wrong, he said that it's difficult to prescribe physical activity if you don't put physical activity in your personal to-do list. So you should walk the talk. So if I'm checking or making just an overview on the healthcare employees or politics or the education employees, they are probably the worst. So they don't do anything for themselves. So credibility it's very difficult sometimes. I see in companies, they invest a lot of money on corporate programs. They do something for their employees. So it's difficult for me, to face an institution, I'm just trying to provoke a discussion, where they don't do anything personally, individually. So what can we do together to solve this gap?
Okay.
Very good question.
Very good question, but I was educated by an internal medicine angiologist who smoked in front of the patients. And he died now with a stroke, and sorry about this, but that is not a role model. But you not have to be heart disease to be a good cardiologist. You have to be a good advisor. And even a doctor can fail in personal achievements and can be a reliable person to advise patients. I have not a problem to tell my patients that I failed this week exercise standards, and it's not easy, even for me. It's not, even a professor can fail, and this is something which we have also to tell them. Everyone can fail. It's about achievement of better. We don't talk about faults, we talk about achievements.
Mm-hmm. Yeah, I didn't say that's not is not possible. I say that's more difficult. Like parents with son, with kids, is the same. If you teach by showing, if you teach by showing the importance of things, probably is a little bit easier.
I think your line is, you may talk the talk, but do you walk the walk? And I truly believe in that. I'm pleased to say that I've been exercising since I was 5 years old. And we had a discussion after my presentation yesterday with Christian. And if a lot of these things are set as children. And you heard me yesterday say, what are we doing for our children? And if you look at somewhere between the ages of 5 and 10, children reach their potentials for physical potentials, how their strength and their cardiovascular endurance. And if they don't exercise those things at that age, when they get older, they're never going to reach their fullest potential they could achieve. I think the same thing is true in terms of what we do in behaviorism are set when we're young. And I'm so embarrassed when I walk around the United States and I see fat children, and we do have fat children. I don't think they need to be fat, and so we set those patterns, those lifestyle patterns, when they're young, and we have to change that, again, down at the grassroots level. So your point is very good, and I think talking the talk is one thing, but walking the walk is certainly something else for many people, but not all of us.
Just a very short comment. I think what you're saying is that, what you're showing there is that these people who are active themselves are highly motivated. They think they're more believers that this is a good thing, and they are more inclined, therefore, to help the patients as well. So I think it's a sign of high motivation in the healthcare personnel.
Here, one last question.
Thank you all for all the talk and the comments. I have another comment regarding whether exercise is enough. I mean, we all talk about we talk about some behavioral changes and such. I don't talk about the administrative level. I took the initiative myself. I graduated as a med school, and then I learned about the American College of Sport Medicine. I read the booklet, Exercise Medicine, and the Brown Book that had about the chronic diseases and such, and I prescribed them. I prescribed the exercises for my patients, and actually personally trained them as well. So I did all the levels of education regarding physical activity, but I felt that there is a big player here that I'm not considering here, which is nutrition. And nutrition, then when I really took those nutritional courses online and all these other nutritional courses, is then when I combined both, is when I actually really had results with the patients. So I don't know whether we should be pushing exercise as medicine too much rather than pushing exercise and nutrition as medicine in our medical schools. I'm not talking maybe at the undergraduate level, maybe postgraduate, when people are interested in this field.
Yeah, just real quick, that question came up at the end of my presentation yesterday, and I tried to emphasize, I believe in nutrition, and I said it again today. Although I'm a clinical exercise biochemist by training, and my original work started off with lipids and lipoproteins and exercise. You can't understand lipids and lipoproteins unless you understand nutrition. And so your point is an excellent point, but that's the point we've been trying to make up here quietly. Maybe we should be more, take our shoes off and pound them on the table, like many leaders did years ago, and say exercise and nutrition, because I do think nutrition is very important as well.
Okay, last question. Oh, sorry.
This is just a point. So that's a great point. But again, regardless of the nutrition itself, we have learned that those that do more physical activity, they have more sensitivity nutrition. So what does that mean? That means that people tend to be less dependent on what is called hedonic nutrition, because the good feel that is associated, the good feeling that is associated with physical activity, the patient does not depend anymore, or at least in the less extent, on the hedonic nutrition. And the hedonic nutrition is very much dependent on fat and sugar. So somehow, regardless, physical activity has this hidden effect on good nutrition itself.
So, and now the last question.
Okay, thank you. Let's say there's a young student with some extra time and who wants to change the exercise situation. What would you recommend them to focus on? The kindergarten, school, university? What is the step we could take, or the first step?
I quietly emphasized that yesterday with my very first slide in my family. I believe in accepting responsibility for a lot of things in my life, and responsibility for my good health of my family is my responsibility to teach them the good things. I think it starts at home. First place, okay, and then it needs to be reinforced in public schools. And unfortunately, only one state in the United States and the District of Columbia, the state is Illinois, meet the recommendations that are required in the United States. So the next place I would go after family is I would go to public schools, but you can't put the burden on them. I see that happening too much with take my kid and make him a good kid. I'm working home making my kid a good kid, reinforce what I'm doing. So I'll stop with this and simply say there's not enough money in public schools to do everything that needs to be done. But I think there could be more physical education.
Yeah, in Germany, in southern Germany, we have a program for kindergarten and primary schools, and there are also programs. We have now 100,000 children every year in the program, and 4,000 teachers. So we need to do such programs to enable teachers to do better teaching. But it's really the families, but we have to reach the families who are helpless. We have families who are helpless, about physical activity. We have families who are helpless about nutrition. And this is a national initiative. Exercise medicine is one of the possibilities to reach such vulnerable families. So primary care physician has a chance to talk to them. Because in Germany, patients, the primary care physician sees about 9 times a year a patient family. So he has a lot of contacts. So, but we need a system approach, and from a whole perspective, we need to have several possible changes. The other thing will be this afternoon, occupational. That's the next issue. It's maybe too late for the old people, but we have to do also something with old people.
Right.
No. If you have
a last comment from Mats. Mats also has a last comment here on that topic, and then we have to close the discussion.
Yes, I have a comment. I think it's now people are getting to realize more and more, as I've seen through the last years, that exercise for health, or exercise prescription, exercise is medicine, physical activity on prescription, and so on, whatever you call it, is important. And I think it's time that all of us from different organizations that are involved in this, that means all the way from IOC to EVSMA, to FIMS, to exercise medicine, to ACSM, to HEPA, and so on, and also the cardiologist, and so on. I think we all should try to focus to work together on this. And I think that's very important, because nobody owns this issue. And sports medicine specialist has a big role in this, but also the other specialists as well, it be a rheumatologist or whatever. So I think we shouldn't exclude. And to finish off what you said about your medical student, I think that prevention in society, it's all everybody's responsibility. It's the parents, it's the schools, politicians, and so on. But physical activity for treatment, it's only our responsibility. So I would get your medical students to start there.
I think now that is a really brilliant last sentence, and I think we have walking a walk now, and not talking a talk. And if we walk the walk, then we perhaps are next year on the stage again with some new results, and perhaps with some new programs, and really we are coming closer to our big target and goal. So please give some hands to this brilliant auditorium panel. Thank you so much for being with us. We have now our lunch break. I want to say thank you for joining us. I have to leave now. I'm flying back to Munich. If someone has more interest in wearables, we have our wearable technology conference in February, beginning of February in Munich. It's the only